Hey everyone, welcome to this explainer. If you're a radiation oncology resident grinding through your training, you are in exactly the right place. Today, we're going to synthesize the high-yield, board-relevant stuff on localized prostate cancer. We've got a lot of ground to cover, everything from the absolute foundational rules of diagnostic imaging to the landmark trials that literally dictate our daily clinical management.
Here's what we're looking at today. First up, anatomy, pathology, and risk. Then we'll dive into primary management trials. And finally, defining relapse and salvage.
All right, let's jump right into part 1, anatomy, pathology, and risk. Okay, take a look at how clearly prostate cancer pops on imaging here. Because prostate adenocarcinoma is supercellular, an increased nucleus to cytoplasm ratio and smaller luminal spaces, it shows up as this distinctly dark, low-signal or hypointense lesion. And that's sitting right against the normally bright, high-signal background of the peripheral zone on a T2-weighted MRI.
Looking at the zones themselves, we got to remember that the peripheral zone, which sits posteriorly, is the biggest glandular piece of the puzzle and, no surprise, the most common site for cancer. It naturally has that high T2 signal, which is exactly why those dark tumor spots stand out so well. This is literally the exact opposite of the central and transitional zones, which just naturally have a lower T2 signal to begin with.
Right, moving from imaging over to pathology, we absolutely have to talk grading. The real clincher here is the strict less than 5% rule for calling a tertiary Gleason pattern. This is a classic ultra-high yield pearl for the boards. So remember, tertiary patterns are only reported in radical prostatectomy specimens, never ever on biopsies. And if that third higher grade pattern takes up more than 5% of the tumor volume, boom, it's no longer tertiary. It's immediately bumped up to the secondary pattern. Nailing down a true tertiary pattern is absolutely crucial because it directly ties to a higher pathologic stage and way higher rates of biochemical recurrence. So, building on that risk profile, let's look at how we actually detect these cancers out in the wild by comparing the big PSA screening trials. The European ERS-PC trial was a huge deal. It showed a 21% relative reduction in prostate cancer mortality just by using a PSA screen alone every 4 years. But then you look at the US PLCO trial and nothing. No significant mortality reduction at all. Why the massive difference? Well, it turns out a whopping 86% of the guys in the PLCO control arm were getting PSA tests on their own, completely outside the trial protocol. That kind of massive contamination totally masked any true benefit of the screening.
Now, once you've actually detected the cancer, you need to estimate the pathologic risk, and you need to do it fast. You are definitely going to want to just commit these Roche formulas to memory. They're your absolute best friend for rapidly estimating the risk of extracapsular extension, seminal vesicle invasion, and pelvic lymph node involvement. They mathematically mash up the PSA level and the Gleason score to spit out a percentage risk. And that number, it directly dictates your target volumes when you're doing your radiation planning.
Okay, moving right along to section 2, primary management trials. All right, picture the scenario in your clinic. A 62-year-old guy walks in with a PSA of 4.8. His biopsy shows super low volume, low-grade disease, Gleason 3+3 in just 2 out of 12 cores. The MRI shows nicely organ-confined CT1C disease, but he's stressed. He looks at you and asks, "Doc, if we just sit on this with active surveillance, am I throwing away my long-term survival compared to getting radiation or surgery right now?" Well, let's look at the data to tackle this.
The absolute best answer for him comes straight from the UK PROTECT trial. They randomized men exactly like our patient, mostly low-risk CT1C Gleason 6, and put them into active monitoring, dose-escalated radiotherapy, or radical prostatectomy. The 10 and 15-year outcomes are wild. Prostate cancer-specific mortality was incredibly low, literally hovering around 1%, and it was basically identical across all 3 groups. So you can tell him active surveillance is incredibly safe for his survival. But, and it's a big but, the trial also showed that active monitoring does carry a notably higher risk of clinical progression and distant metastasis down the road compared to just knocking it out with definitive therapies.
And honestly, these functional trade-offs are the real meat of the shared decision-making conversation. Check out the sharp differences in early functional outcomes here. At the 6-month mark, you're seeing significantly higher rates of sexual dysfunction and urinary incontinence following surgery compared to radiotherapy or just active monitoring. It's a huge quality of life factor the patient has to seriously weigh.
But let's change it up. What if our patient actually had intermediate risk disease and needed a short course of hormone therapy with his radiation? Does the timing matter?
Well, the Malone trial answered this by randomizing over 400 guys to get 6 months of ADT either totally neoadjuvantly, meaning before the radiation, or concurrently starting at the exact same time. And guess what? At a median follow-up of 12 years, there was literally zero significant difference in overall survival, biochemical control, or late toxicity. So for your intermediate risk patients, you can confidently start ADT either neoadjuvantly or concurrently. The outcomes are equivalently excellent.
When we get to the actual radiation, dose and modality are the big questions. The Zeitman trial proved that bumping the dose up from 70.2 grays equivalent to 79.2 absolutely crushed it for biochemical control, dropping failure rates from 32% all the way down to under 17%, especially for the low-risk guys. But, and keep this in mind, it did not move the needle on overall survival. Also, when patients inevitably ask you about the newest, flashiest tech, you can point them to the recent Astro 2024 Paired to Quality trial. They pitted proton therapy against IMRT and found absolutely no clinical difference in early toxicity or outcomes at 24 months. None.
Which brings us to our final section, defining relapse and salvage. Let's run through one more clinic consult. You've got a 67-year-old man, 6 years out from a radical prostatectomy. Now, his PSA is creeping up. It's at 0.6 with a doubling time of 9 months. He feels totally fine, and his conventional CT and bone scans are completely clear. He technically meets the criteria for biochemical recurrence, so he asks, do I start hormone deprivation therapy today, or do we hold off? Managing a case like this in the era of modern imaging is a fascinating puzzle.
Historically, to even call it a failure post-radiotherapy, we leaned entirely on the Phoenix definition. That's a PSA jump of at least 2 nanograms per milliliter above the absolute lowest point, or nadir. And we called it at call, meaning no backdating. It was a really solid rule because hitting that nadir plus 2 mark is a strong predictor for overall survival and distant metastasis. But today, that historic threshold is getting seriously challenged.
And here is why. Modern imaging has totally flipped the script, creating this massive clinical gap. PSMA PET scans are spotting physical, local recurrences way before a patient ever hits that old nadir plus 2 criteria. I mean, look at this. The IBER study hit a 57% detection rate at a median PSA of just 0.83. And for Althi, they saw a 34% detection rate when the PSA was just hovering between 0.2 and 0.5. We are literally seeing the cancer on a screen long before the blood work officially flags it as a failure by the old standards. So what does this mean for our timeline? Well, the TOTE trial tried to figure out if we should jump on ADT early or just wait it out, which is exactly what our patient was asking. They took patients with a PSA relapse and randomized them to either immediate ADT, meaning starting within 8 weeks, or a heavily delayed approach where they waited over 2 years until the guy actually developed symptoms, overt mets, or a really scary doubling time. The results? The immediate ADT arm had a 91.2% 5-year overall survival, beating the delayed arm's 86.4%. On paper, that looks like a slam dunk for early intervention. But hold on, there is a massive caveat here that you have to remember for the boards. The trial was actually stopped early at 8 years because they just couldn't accrue enough patients, and there were only 46 deaths across the whole cohort. Because it was so underpowered, those survival results are still fiercely debated by oncologists today. And that brings us to a final, really provocative thought. Our classic trials, like TOAD, were built on much later detection thresholds from the pre-PSMA PET era. So as PSMA PET uncovers micrometastatic disease at radically lower PSA levels, are we ready to just completely rethink when we pull the trigger on salvage therapies? Will those legacy timing rules for ADT even hold up for the next generation of patients? Or do we basically need to tear up the playbook and start over? It's a huge question, and it's one you'll be answering in your own careers. Thanks so much for hanging out for this explainer, and good luck with the rest of your training.